heard that this is your first intern education session, so yeah, really pleased to be part of this. I'll get cracking into this. Again, this topic is one of those ones that's just going to come up time and time again because deteriorating patients is pretty much what hospitals seem to be all about. The theme of this, I'm going to tell you the way I approach stuff because I do this all the time. I've done it for many years, and hopefully you can take something away from the way I do things in this space. So I always say this thing: always keep perspective. You've already won at life. This will be one of the most challenging, few years of what you're ever going to do, notwithstanding COVID. And but it's actually life is still pretty good for most of us in the history of life ever. So even if you fail everything from here on, just remember you're all still good. And journey like the medical career you're about to embark on is just such a rewarding thing. And there's so many good resources out there. Make sure you have a GP. Don't forsake your friends because they're so useful. I'm getting older now, and my friends from university and early years of training are just so important to me even now. And just a whole lot of resources. This great book here, Also Human, it's chilling because I read it after doing most of my career. But it's literally stories about all the different episodes that have happened just during my early training years. So really, really worth a read. Now the ground rules, look, I will ask people, it's a safe space. I don't care if you say a great answer or a terrible answer. I just want you to put your thoughts out there. And as you know, failure is the only road to success. So I will pick on people, I ask people to volunteer information. Feel free to stuff it up completely. I know that I do all the time, and it's far harder to stuff it up as a consultant. You feel so much worse. So if I ask you a question, don't you worry about that at all. If you're really, really into anesthetics, this is a quick plug from where you can get more information from the things I run. I run a bootcamp series for Anaesthesia, and it's on my website there, which is called anaesthesiacollective.com. This very same lecture, but with back the last year we had it, we actually managed to get space in the Sim Center and do a bit of a live session. So if you want to watch that part of it as well, totally can watch that there. And I've just put a QR code there if anyone wants to have take a screenshot of that as well. Okay. Hey, so I'm just going to throw it out to people. What do you guys want to know? Just tell me anything right now. Go for it. Yeah.
Just like the basic responsibilities of the intern, what our role is in all this.
Fantastic. Okay, definitely go through that. Just one more person. Anything specific you guys would like to know?
I'll jump in here. I suppose if we get called for a UCR, that then evolves into a med call if person's like deteriorating. Mm-hmm. What can we do in that period of time until like the rest of our support comes up?
That's a really great question. So a lot of the time, you might learn a lot of high-end stuff, but it might not be your scope of practice, and maybe you just don't have the skills to intubate yet or draw up adrenaline. Absolutely. So knowing it at your personal level is a really great thing to do. Excellent. And someone also mentioned processing multiple calls simultaneously, and that is going to be hard for anyone. Okay, so let's cover. So first of all, let's cover this stuff. How do I know when someone is deteriorating and they're sick? What do I do if my patient's deteriorating? So I'll give you lots of steps that you can do even as an intern. And then I'll just give you a lot of the frameworks and things that I think about and the way I chronologically process a deteriorating patient as well. Hey, so first of all, I'm just going to ask someone now. I might ask Nicholas Kazantzidis. Just love the name. I love a good long name, because mine is as well. How do you know when someone's sick, Nicholas?
Few ways. They'll generally look sick. They might tell you they're sick, and obviously going more medical, often vital signs can tell us as well a lot too. But general inspection is probably the best way.
Hey, I really like that because there's just so many obvious things. I think a lot of what med school does is it takes away our common sense about stuff, and just know that you'll be able to know without any medical knowledge if someone's unwell, just from what you said, just looking at them. So the obvious things are vital signs and other numbers and tests. Put your hand up. Has everyone seen the color grading scores? Yep, good. So these are really useful things. So you know that these are almost mandated times when you should call someone, because vital signs shouldn't be outside those ranges. And that's a really useful thing that's only come in, I think, in the last 10 years. So it's a reasonably new thing. And it's definitely one of those really great initiatives to improve patient care. And then, just the look of the patient, that general inspection. You might know that the age of someone means that they're more likely to have problems, super young ages as well as really old ages. The color of that patient, really one of those sad things. I remember the first time I saw someone dying or on the way to death, it's a very specific look. And once you've seen that, you'll know that as a red flag. Like I was recently just working in a private hospital, and the nurse ran in. It's a small hospital on the floor of a multi-story building, and the nurse ran in and was like, "Oh, I think the patient's unwell." And I ran into the recovery, and there was a guy who just had very minor operation with minimal anesthetic, just lying there, lifeless and grey. And I thought, I've seen this look before. And as soon as that happens, you kick into action, because you know that look, and that look means that you don't even have to worry about whether there's a pulse or whether they're breathing and doing all the formal things, because you know that look is so bad. So the colour and everything's definitely part of it. Someone might have obvious distress. When you see someone who's rapidly ventilating and has that look of using their accessory muscles, and their chest is rising and falling rapidly, and potentially they're just agitated, that is a sign that things aren't going wrong. So again, using that common sense to escalate and call for help is really, really useful. Has anyone heard of the O sign and the Q sign? Hey, so this was from how over time there's like certain books that just define a generation of medical practice. Well, the House of God was that particular book, and a lot of the terms you might hear, orthopedic height, neurosurgical height, Gomez, O sign, Q sign, it's all from that book. And O sign is literally this. You'll see that patient a bit unwell, and their mouth just seems to be open. Q sign is even worse, and that's O with a Q. I can't believe I'm doing this for a video. And so when you see that, definitely a thing to think about. And I've got to say, most of my fractured NOF patients all have O sign. So that, they've got high periop mortality. So that's my N equals 100 or so. Now, let's get into some of the real stuff. So what do you do when a UCR, so urgent clinical review, evolves into a MET call? That's a fantastic question, because then actually the process I go through will allow you to have roles and tasks that you can do. So we can definitely do those things. Actually, as a general thing, you will have, I'll teach you a process of, what you've probably heard, doctors A, B, C, D, E, and that's the way you will slowly assess and stabilize a sick patient. Now, in real life, you'll have lots of people coming into the team, and often those people will be senior, experienced residents, registrars, consultants, nurses, clinical nurse specialists, and all of that. And so I always have this thing where once the room gets busy, and people are already doing those doctors A, B, C, D things, what are those peripheral things that an intern can do to support that team? I might just ask someone just to riff right now. Aaron Bart, I might just ask you.
Sure. Maybe the intern. Can you hear me?
Yeah, absolutely. Go for it.
Right, so maybe the intern could do something like, if somebody needs, like a syringe or a cannula, we could go and fix those things, perhaps, or we could, or we could maybe, I don't know, interrupt medications if they need that, like adrenaline or those kind of jobs, and then give them to the people responsible for each thing, like listening Airway.
You're absolutely right. Like those are the things. Like think of all the things you know how to do within a skill set, and you can do it. So yeah, if you're happy drawing up adrenaline, fantastic. If you can put a drip in, fantastic. If you can get the EMR up. You know how long the EMR sometimes takes just to get up. You can absolutely do that and be so useful when you do that as well. And then someone's also written here, fantastic. Yeah, background history. Once you get the EMR up, the drug chart comes up, and now you know the background history, and you can collaborate with someone who is there already. Often you'll be the person that knows the patient, or you and the nurse will be. So you'll step aside and go, hey, this is what's happened, hand over, and then start getting these peripheral stuff ready. And yet, scribe, order investigations, call and get tests organized. Absolutely. Excellent. So that's probably the major role that I had as an intern once everyone had come into that. So
I want to just put in here that some of the consultants who are less in the acute space, so the hero you might not even, this might not resonate with you. Some of them are very unfamiliar with the EMR and will really need you to help them out with that. So it's a good role to take.
Yeah, and it's so true. I find that the more that I am supervising, and the less I'm actually getting into checking chest x-rays and bloods, because my registrars are doing it. I hate the fact of how lacking I am with EMR knowledge sometimes, or when they put up some extra function in it. I am embarrassed at how this is, but you know what, you'll all be there as well, so I'm not going to worry too much about this. Okay, so back in med school, so you were you learned to approach an approach to assess any patient. So someone who presents with joint pain, shortness of breath, chest pain, headache, how do you assess any of these patients in general? What do you reckon?
So like you said earlier, the A, B, C, D, E assessment as always at start.
Beautiful. And if they weren't unwell, which approach would you take?
If they weren't unwell, probably work system by system. So check the most like kind of urgent features first. So
hey, you're actually saying all the right stuff that I want you to say, and the stuff that med school will teach you, generally speaking, will be history, examination, investigation. But you're absolutely obvious, right? You're absolutely right. So what I'm getting at is that history, examination, investigation is the tools we have to diagnose stuff, and that's so important. This is kind of the answer you give to any question. Like a patient comes in with a flare-up of arthritis. How do you assess them? History, examination, investigation. Pain, history, examination, investigation. Fluid status, history, examination, investigation. But that is only when they are a well patient. So this is roughly the framework that I have in mind when I think about assessing anyone. Management, which is the holistic assessment of someone, will be assessment, which is history, examination, investigations, and then treatment. And then you can divide that up into conservative and invasive, and that can be pharm, non-pharm, interventional, surgical, and whatever other magic we discover in the next few years, decades, whatever. But that's the framework that I was taught time and time again before I really got into kind of the crit care space. Back when I was doing this, ALS and BLS was just something that you did, once every few years. It just wasn't that taught and drilled the same way it is now. So the next question I'm going to ask, I'm going to ask the room with 4 people. That's exciting. So Hugh, Jordan, Ty, or Greg, can you treat someone without a diagnosis?
Yes.
Yeah, nice one. I love brevity. I hate waffle, so I'm really appreciate it. And why is that, Hugh? Or Hugh, or Jordan, or Ty, or Greg? You look like a Hugh, so I'm gonna.
Differentials, the treatment is the same for all of them, so nailing exactly what it is doesn't matter. And then other times you're not treating a disease so much as managing vitals. You're not necessarily treating someone's asthma as managing their breathing or airways.
And I totally agree. So, and why is it? Why don't we need a diagnosis to treat?
Yeah, so similar to what you were saying, it's just about managing that situation critically, and then you'll try and improve that person's baseline function and do some more tests to help that.
Exactly. I like the example of asthma. It's like asthma is this whole process and needs various treatments. But if they're hypoxemic, that's easy. Low oxygen equals oxygen. They're alive because of the oxygen. I don't really need to know if it was asthma or COPD or all the detail of that, which is really satisfying when you're anesthetics for crit care, because if you've got a short attention span, you kind of just get to solve it straight up and then hand it over to the physicians for some nice chronic, yearly, decade-long management afterwards. So this then leads on to why is trying to get a diagnosis bad practice. I mean, it's because it will take time to delineate the exact cause of what's going on when all you needed was oxygen and to put that on. This wasn't obvious back in the day, and that's why it's such a big deal that we teach this constantly, and you guys express that really well. So is treating someone without a diagnosis sometimes the best thing for a patient? Absolutely yes. If they're hypertensive and all they need is fluid, why do we need to know exactly what that cause of hypotension is in that immediate setting? We don't. Cool. So what framework can we use? And someone's already mentioned doctors A, B, C, D, E. What does it stand for? I'm just going to ask someone now. Cameron McGrath, what do you reckon? What does doctors A, B, C, D, E stand for?
Danger, response, send for help, airway, breathing, circulation, disability and exposure.
I love that you got that, Cameron, because when I run the ALS sessions and people have to pass this to get their ALS2 certificate, people forget these letters. It's such a basic thing, but literally people forget these letters. So I thank you for getting the letters. So danger, response, send for help, airway, breathing, circulation, disability and exposure. So why don't in this first part of the talk, let's go through each of those and just action some things that you can even do at a basic level. So why is this useful? When you think about this, it makes logical sense. The reason you are alive is because your airway is open and it allows a passage for an oxygen molecule, 21% in the environment, to get into your lungs. The lungs are working properly. They don't have fluid. They respirate. They ventilate in and out. to allow that to happen, and then across that pulmonary capillary and the alveolar membrane, you get the oxygen diffusing across, and then you get it attached to a blood vessel or blood cell, which then is pumped around through the circulation by the heart to tissues. So really, if the patient has an open airway, breathing, and circulation, really those are the life-giving systems. So that's what we check time and time again. So think about this: sick patient equals stabilize and optimize, which is doctor's ABC. Well patient is assessment treatment, and the longer, more subacute history examination investigations. So a quick summary of this. So that's kind of what we just talked about: assess and optimize using that format. But what do you actually do? So danger is kind of the obvious stuff, and in this day and age of you've got to protect yourself from really infectious things like COVID. It matters far more, you know, that you put on gloves and personal protective equipment, and often it's the N95 masks and everything else you need to do. But also things like if I was just to ask someone, hey, Sasha, if I was to ask you, you've got a patient in who's had a vasovagal or some kind of faint in the shower in a room, you know, what do you do to as a danger step?
Ensure there's no electricity to the area would be probably one thing, but also we shouldn't be moving patients by ourselves. So there's also manual handling dangers to us and slip hazards with the water. So like turning the shower off is probably the first step.
Yeah.
If you can do that safely, and getting other help there to get the patient somewhere safe.
Absolutely. There's something about you just can't resuscitate someone in the wrong position, in the wrong place. So making the environment suitable to you is absolutely vital. So get your team together, call the security, call the staff, move the patient into a place where that's bigger. Like I've seen everything from, you know, getting patients, moving them into the room, taking other patients out of the room to give yourselves more space. So now you've got a patient in the corridor, so you've got enough team and space in that one room, which had 2 cubicles previously. Getting the bed head off and pushing the bed out from the wall, so you've got now space for people at the head of the bed. There's so many things you can do, even as an intern, to make the environment perfect for you and your team. And they'll thank you for it, because trust me, your seniors and experienced staff will be cognitively overloaded, and this will really help. In terms of response, how do you check for a response? I'll ask Anmol Shah.
Yep, so for response, first of all, you can try to get sort of a verbal response from them. Ask them, can you hear me? What's your name? And then if they're not responding to that, then you can go ahead and try to get use some stimulation, so trap squeeze, pinching the end of their finger for some pressure points. Yeah, perfect. And that easy scale is AVPU alert, naturally alert, to voice, to pain, and then unresponsive, so AVPU. And I always have this thing where as a junior doctor, I get called to an unresponsive patient, and like 99% of the time, they might have been unresponsive to the person that called me, but they weren't unresponsive to me. So it's like a badge of pride where I'd get up there and just go like really loudly, "Hey, Mr. Jones," and just see what happened. And so, just make sure you don't have to be shy about this. You want to make sure that this patient is absolutely unresponsive, because remember what it means. If, let's say this patient was narcotized and you checked for a response but didn't really shout loudly, didn't really stimulate the patient, and they weren't, they're breathing very slowly and because they were narcotized, you want to make sure that you don't start CPR on someone who's just narcotized, that would have responded to increased pain. And in terms of the appropriate things, it always changes, but nail bed pressure is pretty harmless and a very good point of stimulation, as well as a trapezius squeeze. But you can find a way. Definitely don't do sternal rubs on patients who've just had a sternotomy, and use your common sense with that. So make sure that your shout is loud and your pain response is adequate and not going to cause harm. Now, what is the number in this hospital to send for help? Anyone can answer that. I'm going to ask someone. Taryn Campion.
Sasha's responded already with 2222.
Fantastic. And I believe that's the rest of all hospitals in Australia, Victoria now. Can anyone confirm for me that?
The UK.
Oh, the UK. Okay, good. So great. So now it's a standardized number, 2222, which is fantastic. And I've mistakenly put 444 because that's what the old number used to be. So I apologize for that. But again, wherever you are, get some kind of response by shouting or a buzzer, calling 000 if you're outside, and 2222 in this hospital. Okay. Now, the next few things, these are all things you really have to just get your hands on and do. I encourage you, if you get an anaesthetic rotation, or even come on, if you're interested, come and say hi to one of the anaesthetists, say, is there a spare theatre? Because we'll be able to train you guys up on a lot of these things. So I might just ask someone to volunteer. How do you assess and then manage the airway with the basic stuff that even interns and junior staff can do?
I suppose if they're speaking to you, we know it's clear, but if they're not, then we can do things like a jaw thrust or a chin lift and a head tilt. There are ways to open up the airways.
Mm-hmm.
We can also, usually without COVID, use adjuncts too to help open up the airways if they're sort of any supraglottic stenoses.
Yeah, and that gets so complicated, absolutely. The framework I always have for this, firstly, assessment is, patient talking, absolutely. Then I just look and listen, look for obvious stuff that's obstructing, often not the case in hospital unless you've got to suction out things. And then I listen for obvious things. Anytime someone has some kind of noise, stride or wheeze, gurgling, that is a really bad sign, especially if you don't have the abilities of intubation. And so look and listen, and then do those things you mentioned, which is, remove the object, position the patient. Easy airway maneuvers are making sure you've got that sniffing, the morning air position, as well as a little head tilt and the jaw thrust. And jaw thrust has an extra thing of being a bit painful, so it can awaken the patient and improve their breathing as well. And then I just put apply oxygen immediately because that always happens there. Just know that if you haven't done LMAs and if you haven't done intubation, you just won't need to do it. There's so many things go wrong with trying to do those things that the harm-benefit equation is far towards not doing it. So giving oxygen, getting that Air Viva bag on, or the Liddell bag, and doing jaw thrusts and doing the best you can with supporting ventilation is just a really amazing thing that you can keep someone alive for that long just using those things. So at each point, does anyone have any questions about that before I move on from each section?
What about situations where oxygen's harmful?
I'll say it again, Shasha.
What about situations where oxygen's harmful?
Yeah, so in the acute setting, I'm going to tell you a rule that if someone's hypoxemic and they look unwell, you won't have a problem giving oxygen, especially in that short term. It is far better that you just give it, and it just won't cause a problem in that short term. So even the most COPD, you're talking about kind of hypoxic drive patients? No?
No, I'm talking about more like routine administration of oxygen with MIs and strokes.
Yeah, okay. Okay, so that, in the context of someone deteriorating, I don't think it would be a problem. And correct me if I'm wrong, if there's a study that says that we've got a deteriorating patient harm with oxygen, I'll stand corrected. But if someone is deteriorating...
I think you're right. I think it's, if they're hypoxic, you apply oxygen, but just not as a routine measure. So like if they're satting at 95, 96, you wouldn't just pop oxygen on them.
Yeah, absolutely, potentially unnecessary. And the caveat I say is, if their sats are good and I expect them to deteriorate, I'd have all of it ready in that very specific context. Now, that said, I've got to admit, I'm not all over the research of how much harm will be caused by it. So and I'm talking from a very anesthetic point of view, where all of my patients rapidly deteriorate from a airway hypoxemic point of view. So even if someone's 96, I just put on oxygen because the likelihood of them deteriorating is very likely. In the ED context, in other contexts, I completely agree that you wouldn't just put oxygen on. No, that's a really good question.
Can I ask, with the amount of oxygen you would would you recommend being judicial based on the saturations, or would you opt to just go high and fast?
Yeah, again, if someone is deteriorating, I would just go start high, and then you can always titrate down. I always think of the amount of room I have to move with something, and especially if I've just arrived at the bedside, and for example, they have very little reserve and they're on the way down. It's far better that I'm wrong about giving oxygen at a high flow, and then I turn it down later. Then I start low, and now their sats are 80, and I'm chasing my tail. That's a very specific circumstance. So most of the time, start low, go slow with everything. But in the case of someone deteriorating, just think of all the situations where someone's suddenly bolused morphine and they've become apneic, and now you've had the call and they're looking grey. I would err on the side of more than less and turn down.
If we call a Met call, does someone who can intubate come, or do we have to call a code for that?
Yep, so Met call will get the ice. Oh, look, Sean, you might be able to help me with this. I forget the team that arrives, but if you've got, generally speaking, code blue, absolutely, if someone needs intubation, and be very, feel completely free to err on the side of code blue, because it's far better that people arrive and then go, actually, it's not necessary. Just remember that, even the vasovagal of someone being unconscious, that could easily not be a vasovagal and be something else that requires intubation. And so erring on the side of more staff, I would personally, I'm an anaesthetist, I go to code blues all the time, especially when I was a registrar. I'd rather be called than not. It's so much easier to sort something out than to walk away. Especially the Western, it's a really nice environment. Definitely in some places you train, people get very annoyed, but I just don't think anyone I've seen gets that annoyed about being called accidentally. We often go to vasovagals and we have to walk back, and we just get to go for a bit of a run. It's fine.
So when when a Met call is called, you should be getting the team registrar and the ICU liaison nurse, the critical care outreach team. If the ICU liaison nurse can't intubate, I'm pretty sure they can intubate. But if any additional resources are needed from ICU, they can arrange that, like an ICU reg, to appear.
I've never
have that time. Sorry,
I've never seen the ICU liaison as being trained in intubation, so I don't think that's a thing.
Yeah, it probably isn't. I wasn't sure if they were able to or not. But in a Met call situation, you should have time that if it's looking like it's heading towards needing somebody who can intubate, they can get somebody there pretty quickly. I've got to say, the whole what happens during a Met call in terms of who turns up is a little bit variable depending on campus, time of day, and unit. So there's no easy answer to what happens there. But essentially, support is available. You will get somebody. Registrar and ICU liaison nurse. Yeah, and thanks for clarifying that here. I wasn't sure whether they specifically were trained to offer airway support up to intubation or just...
And the ICU regs are fantastic, but often they can be quite junior. So even the anaesthetic reg who turns up might be junior, and they'll often call their consultant in. There's just so many ways the intubation goes wrong. It's better just to get the people there. So with breathing, I'd say, again, a nice format is look, listen, and feel.
I was just going to make a comment about something I put into the chat room earlier, which was when we were talking about frameworks. That I do occasionally get people trying to apply the doctor's ABC framework to a patient who apply that framework to patients who are walking and talking. And it says to me, you fundamentally don't understand the difference between a well and an unwell patient, at least in describing what you would do. And I think that it's a good reminder to all of us to have those different approaches, to remember that we have different frameworks for different reasons.
Yeah, absolutely. And just even be able to say, this patient looks well, I'd assess like this, or this patient, I'm worried. They look unwell, they could be unwell, I'll go down the doctor's ABCD. So moving on to breathing, I mean, again, looking at someone and seeing how their work of breathing is, paradoxical breathing, so useful. But again, when I communicate this to people, it's, I look, listen, and feel, and then measure. And that way, as soon as you say that, especially if you say that to your boss, they go, oh, this person has a framework, and they won't miss the things that are quite critical for assessing breathing. And again, if you're worried, applying oxygen, assisting with bag mask ventilation, really useful. And then maintaining that airway as well, using all those maneuvers we talked about. Now, the interesting thing with respirate, I think respirate is one of those first signs that actually increases, and also one of the ones that is probably most difficult to measure. You're not often have a SATS probe that just tells you the rest rate. So seeing a trend on a rest rate increasing, a really important sign to look for. Now again, as an intern, I'm just thinking, you may not know how to bag mask effectively, but there's a lot of things you can do on the way there. Getting that Liddell bag up, turning the oxygen on, making sure you have a good seal so there's passive oxygenation. And assisting their breathing as best as you can, knowing that chest rise and fall and fogging of the mask is a good indicator. Circulation is probably one of the most common things. How does someone just generally assess circulation? I might ask, let's say, actually anyone can jump in, or actually I think I was about to ask Taryn Campion. What do you think?
Sure. So probably first off, you'd look at their vital signs, make a bit of an assessment based on that. And you'd check for things like capillary refill time and signs of perfusion, so whether their hands are warm, whether their conscious state is okay, so whether their brain's being perfused. And if you've got any way to measure urine output, that's a good sign to look at as well.
Yeah, fantastic. And I guess circulation is one of those things where there's so much that could be going on, and there's just many, many different approaches. So having, understanding where the patient came from, whether they're like a, potentially dehydrated patient versus a post-op versus an anaphylaxis risk patient or septic patient, all kind of frames the way you approach this. But generally speaking, inspect, palpate, auscultate, measure, and like you said, look at some of those kind of clinical things you would have all learned in med school: pallor, mucous membranes, JVP, cool peripheries, capillary return, and then looking at those surgical sites in the drain tubes, measuring blood pressure, heart rate, urine output, and drains, and seeing the trend of what the blood pressure is doing and what the heart rate is doing. Now, this is where I feel like as an intern, you will be trained and able to do so many of these things, like putting a drip in, putting a big drip in, taking a blood, especially venous gas. And Taryn, why do I want a venous gas?
You can get lots of really useful numbers quickly, so you can get the electrolytes, you can get the oxygenation. Sorry, you can't get the oxygenation, but you can get the hemoglobin, and you can get stuff that you can change.
Absolutely. It's like so many of your reversible causes are straight from this one test, and it gives some of the other indicators. So exactly what you said. You'll get a sense of the pH at least. You'll definitely be able to get the HB. So for volume loss, you'll get the potassium and get blood sugar levels, even some other deteriorating patient conscious state stuff like sodium as well. So much information from this one test. One of those things that we often do in anesthetics, if we need a rapid fluid bolus, is just to put the legs up. So you often might see patients Trendelenburg, so head down, but then with so legs up and the head down, but then the head can be brought up so it's in like a V shape. So that's a good position to have. The V shape is great for ventilation, maximizes the mechanics of ventilation, whereas the legs up allows for the central volume to improve as well. But you can give that small fluid bolus. So there's one of those things I remember thinking as an intern, like how much is a safe fluid bolus? I might ask Karen Vong, if someone, like let's say you get a sick patient with a low blood pressure and you're not sure what's going on, maybe they're post-op, what's a safe fluid bolus to give someone?
Usually I'd go for 500 mils, but if they've got underlying heart disease, kidney failure, I'd think about 250 first, and I can top up afterwards when I think they need a bit more.
Absolutely. So, 250 mils of a crystalloid in these kind of unwell, unstable patients is completely reasonable. That's a cup of water, and you can always redo that if you're getting a good response, or so that number I always kind of stuck with. Whereas for most people, any fit young person, giving a 500 ml bolus is really, really fine, especially if you're worried about their blood pressure and you think they've dropped fluid somewhere. And then obviously getting the ECG machine. These days, getting a point of care echo and learning those skills is actually not such a hard thing to do. So again, something I'd recommend people as they go through their training, as they get more senior, to do as well. And again, as you become more senior, you might be able to drop some inotropes and things for your staff. Maybe not as an intern, but definitely as you become a crick care resident and have done a bit of a few crick care terms. So disability, this is one of those things where decreased conscious state was a thing I absolutely hated having to assess in any patient because there's so many differentials. How would you assess it? Anyone can volunteer for this.
Whether they can stay awake in a conversation.
Mm-hmm. Absolutely. So really doing like the kind of the GCS type thing. Look, I've just got this framework of I check the GCS, but basically GCS is complicated. So AVPU is easy, alert, then alert to voice, pain, and unresponsive. I check pupil size. I check limb for gross neuro assessment, and then D, don't ever forget the glucose. And look, I won't go into this now, but there's so many causes that can change your conscious state. So I think of physiological, pharmacological, neuro, and then other. And that just helps me frame things. I take my ABG and look at my vital signs. That's physiological. I just check the drug chart for all the pharmacological things and see what's being given. And then I consider, is this patient having some kind of neuro issue? And then there's a whole bunch of other weird and wonderful things, just thyroid issues and antidopaminergic agents and things that could cause this. But definitely the common things you'll see time and time again are BSLs being low, so hypoglycemia. And again, the ABG can sort out a lot of these issues, or the venous gas.
Just to link this to the last slide as well, one of the things that your brain needs to function is perfusion. So if your circulation isn't working, your brain's not going to be working, and people go through that delirium, altered conscious state, and completely unresponsive pathway if they're not getting enough perfusion. So don't forget to think of it.
Mm-hmm. Nice. Now the exposure thing, so E for exposure, again, this is really to try to cover all your bases, and the obvious stuff that you'll see that you'll not know, not due to lack of knowledge, but due to lack of common sense and just looking, is to just inspect the patient from head to toe, because you'll be surprised what you see, whether it's a decreased conscious state patient who's got some melena down below, and if you just looked at that and just followed your nose towards the smell, you'd have an absolutely easy cause for that decreased conscious state. But yeah, blood loss, drain tubes, infections, rashes, and then check the temperature of the patient. And then obvious things like putting pressure on blood loss and covering someone to keep them warm. But the inspection from head to toe can give you so much information.
Would you routinely recommend a rectal examination? Let's say you haven't found an obvious cause.
No, it could be the fact that I'm an anaesthetist and I try to stay away from any of that. But let's say I haven't had to do a rectal exam since resident days. And maybe that's because my pretest probability in the anesthesia world is that if I have that as a problem, I already know it's a problem. They're already coming in for a colonoscopy. The gastroenterologist is already aware of it. So that's, in my context, rarely will I need to do that. What are your thoughts, Ash?
Look, it's just, I've had the occasional patient. I've got to say, if you're worried that there's going to be gastrointestinal blood loss or volume loss, it's going to be more likely to be hematemesis, so acute, rather than it's transited all the way through the tract and you're getting melena. But you can get lower tract loss as well. I have had the one or two occasions that have stuck in my mind where a patient has had that sudden deterioration, sudden loss of consciousness, and it's turned out to be volume loss from GIT. But you're right, they've been patients under the gastro unit.
Mm-hmm. So, I mean, this could be a really refreshing thing for the interns. Are you saying, Sean, that if they've got this, you don't have to do a PR? Because that might be...
It's obvious. I'm just saying a couple of times we've done the fully exposed them.
Yes.
And said, oh, wow, that's what the problem is.
Yeah.
And it didn't need a PR, no.
Yeah, okay, good. I think Pia raised their hand. Please, go for it.
Yeah, I was just wondering, with the PR, is that more checking for spinal cord injury rather than lower GI bleed in that context of a doctor's ABC?
I'll let you handle that, Sean, because I've actually never checked a PR for spinal cord injury. I know that my diagnosis of that will definitely not depend on the PR, so I've never had to do that. Everything that in my circumstance, my environment, I'm treating, I'll already know what's going on with the spinal cord, which won't really depend on that, but definitely that will be part of an exam for other reasons and other settings and potentially trauma settings as well. Sean, do you have a approach for that?
Yeah, absolutely. I mean, if you're looking for anal tone and you're thinking about a spinal cord injury, that's a completely different setting. And I think, as Sasha's pointed out, that we're talking about a patient who's in ED and maybe has had trauma or the pattern is very different to your suddenly deteriorating patient.
Yep, good. That's probably, again, another reassuring thing. A lot of these investigations and things are, they're awkward to do, even in a deteriorating patient. And it's good to know what is necessary in certain circumstances. And, at this level, obviously, you can always ask and these kind of tricky situations. So the next thing I'd say is, can you remember all this? And, you know, the fact that I teach this time and time again means that, you know, I'm teaching and I'm doing it, so I probably can remember it, but know that your memory is so fallible in many ways. So, you know, just, I just feel like it doesn't matter. If you've got a phone, you can just take these slides and just chuck it on your phone. And as you're in the team going through things and everyone's acting and going through things, you can use this as a checklist and just see that, is everything being done? That in itself can be a very useful role of someone who doesn't maybe have the level of, you know, experience and competence, but you still have access to knowledge, and you can checklist the other people in the room, make sure that other things aren't missed. Has the blood been taken? Is this patient do they have oxygen? Is it relevant? Things like that. Yep, so what I've said is the age of access. Just use your memory for the frameworks and structures and emergency stuff, and then, you know, use Evernote, use OneNote, use whatever notepad you need on your phone. So what next? Now, after you do your doctor's ABCD, the very next thing I do is the reversible causes and looking for the diagnosis. So let's look at this little framework to make this a high yield thing. So now, often you'll think of reversible causes in the context of advanced life support. You know, so you've got the flow charts, you're doing the patient's arrested, you're doing cycles of CPR and adrenaline and all the rest of it, and then you take a step back and check the reversible causes. But this was the one thing I did as a resident that I find really useful, which is why not use that for deteriorating patients as well? It's a slightly different context, but again, very, very useful. Just to recap, we got the sick patient. They get the assess and optimize doctor's ABCD approach, and then you check for reversible causes. Again, you can do that as an intern. Again, it just requires a bit of effort and work making up a table, and I'll show you the table I've got now. Can anyone tell me the reversible causes? In fact, I'm gonna pick on someone. Julia Liu. And you know, it's great being asked this question first, because then yeah, you get to answer a few of them. Go for it.
So those are the 4 H's and 4 T's.
Yeah,
so
sounds
4
good.
H's: hypoxia, hypothermia, hypokalemia, and hypovolemia.
Perfect. And just with that, it's hypoxemia instead of hypoxia.
Okay.
Good. And how about the T's? You're doing so well.
Yeah, and the T's, tension pneumothorax.
Mm-hmm.
I want to say tachycardia.
It's not tachycardia, but that's all right.
Tension pneumothorax.
You've done really well.
Cardiac tamponade.
Tamponade, absolutely. Tension, tamponade. And then there's 2 more. Thromboembolic, which is PE, so, you know, PE as thromboembolic, or cardiac thrombus, AMI. And then there's toxins, which is kind of like your drugs and your drug chart and things. So that's your frame. And I always thought that it was really strange to have a mnemonic that's all the same letter, because it just wasn't as helpful. You know, hypo doesn't really help you remember the kalemia, thermia, emias, and all the rest of it, right? So I was trying to think of just a better way for you, and there's many ways you can remember this. So the 4 H's and 4 T's, you'll often see a diagram like this, which could be useful. So the reason I said this is just one of those things that helps me communicate specific things in physiology. Hypoxia is when it's tissue level lack of oxygen. Hypoxemia is low oxygen in the blood. And so it just helps me communicate very specific physiological things. I get that lots of people use them interchangeably. The causes of hypoxia are if there's not enough blood, if the heart's not pumping, if there's not enough oxygen, hypoxemic hypoxia, or if there's cytotoxic issues like mitochondrial, carbon monoxide poisoning of the mitochondria. So your cause of hypoxia are at a tissue level, hypoxemia is at a blood level. Let's get all physiological there. And then you got tamponade, tension, thrombosis, and toxins we mentioned. But look, if I just told you now heart, lungs, and blood, I might just get someone to just tell me what the causes are by using that as a framework. I might just ask Daniel M. Just to go through those causes again. Hopefully you didn't know them that well, and now just thinking about heart, lungs, and blood helps you get your results out.
So for heart, you'd be thinking tamponade again.
Mm-hmm.
Yep. Sorry, I'm just trying to reimagine it.
Yeah. And so what are the things that could kill you that are heart stuff, lung stuff, and blood stuff? And sorry to put you on the spot, but you're doing well.
Daniel, I've put the H's and T's in the chat in case it helps you. I hope that's not undermining the lesson that you're...
That's definitely undermining the lesson,
No,
Sean.
that's okay. I was trying to don't look. I haven't seen them. Yeah, so lungs, tension, pneumothorax, thromboembolism, as well, I suppose.
Yep.
And hypoxemia.
Perfect.
And blood hypovolemia.
Perfect.
Toxins. How many is that? I've forgotten how many.
No, that's really good. So you already said thromboembolism, which is also heart and lungs, but you said it, which hopefully means you'll prompt it even if you say it in the lungs. So AMI and tamponade. The fact that someone said tachycardia is actually real, you know. A deteriorating patient can be due to heart stuff, including tachycardia. It's just a bit more obvious and less of a reversible cause because these are more need to be uncovered, whereas tachycardia is a very obvious thing. So you're absolutely right whoever said tachycardia, bradycardia, tachycardia, multiple things, but those are easy to see. Hypoxemia, easy to see, but it's lungs, pneumothorax, PE. These are all things that kill people due to lungs. And then blood, easy. There's less blood. The blood contents, whether it's electrolytes or pH or whatever it is, the stuff that you can measure on your ABG or venous gas are a problem for life. Therefore, blood stuff is important. And then I just think drugs are in the blood. The final thing is temperature. And often, unless you're in another setting of remote or recovery medicine, drownings, for example, temperature won't be too much of a problem for you in a deteriorating patient in hospital. So heart, lungs, blood, again, doesn't matter what mnemonics you remember. Try to remember 4 H's and 4 T's because everyone says that, but this is my framework of thinking about it. Now, in the interest of time, I'm going to, like this table, feel free to take a screenshot of it. I just made this like back years and years ago, hence the terrible formatting, not worthy of a YouTuber. But I just went through what features on history, examination, investigation would mean that I would think about each of these as differentials. And I realized that a lot of things are just pretest probability. And you wouldn't be surprised to see that when people in simulation, for example, when we're constructing these scenarios, we really, try to take a patient, like say a patient, and then think what's most likely, and then chuck in a problem. So imagine like you've got an end-stage renal failure patient. Oh, well, that's generally an old patient with bad kidneys equals hyperkalemia or AMI. Or maybe it's a post-op patient, with trauma of the legs or a knee replacement. Then I'm thinking, oh, it's elderly patient, yeah, AMI, PE from a DVT. So if you think of the history that leads to something, it can be very useful for your diagnostics. And it's how we think of what is most likely in this patient versus what is, going to be, like 4 H's and 4 T's for everyone. Likewise, you can see there's only a few investigations that you need to do that are incredibly high yield and that you can do as an intern already. Again, venous gas, get the vital signs on, a lot of things you can do. So I won't go through that in too much detail. Takeaway points from that. Think of the pretest probability of what this patient is likely to have. Young patient, unlikely to have a heart attack versus, having some other thing like toxins or tension pneumothorax. Post-CAGs or a trauma patient, yeah, they're going to have chest trauma, therefore pneumothorax, tamponade is more likely. Tamponade is very unlikely in so many other contexts. At times, New Roman, no less. Love it. Hey, so I think someone's just asked, so I do have lots of in-person tutorials. So in-person Zoom tutorials, check on the Anaesthesia Collective website. Definitely have lots of in-person tutorials there. If it was a cannulation, if it's cannulation sessions, I haven't run one of those in a long time. Hey, but with enough interest, I'd love to run a cannulation session. So pretest, the next question is pretest probability. Look, it's really just the probability of a patient having a disorder before the diagnostic test result is known. So the way I can explain that is, if there's such a stereotype, but often true, an 80-year-old Maltese smoker comes in with a bit of, yeah, exactly, AMI, right? It happens so often that this stereotype is a true stereotype. So if this patient comes in even with, let's say they've got a bit of funniness in the chest, that's a heart attack. If they come in with funniness in the chest and a negative troponin, that's a heart attack. Normal ECG, that's a heart attack until proven otherwise. Your pretest probability is so high that even if the test tells me no, I'm still suspicious. What you know before the test matters when you want to know what the test and the context means. Likewise, someone who's young with no history, female non-smoker, having funny chest pain, even if they have a raised troponin of some sort, you're thinking this is probably not a heart attack. It's probably SVT or some kind of tachycardia that's happened, causing that troponin rise to happen. And you'll get an idea of this as you do more and more experience. So exactly, like using the outer ankle rules before X-ray an ankle. Yeah, I don't know those rules, but I suspect exactly what we're talking about here. Paolo, did I explain it? I'll definitely, please let me know if that wasn't a good explanation.
That was good, thank you.
No worries. So again, this is really great for exams in life. If you know where a Viva or a sim scenario is heading, think of pretest probability. That's kind of the cheat codes for this. So just to recap, we've got the sick patient, doctor's ABCD stuff, just learn it from the slides, checklist it, reversible causes, think of pretest probability, and use that not just in arrest patients, but deteriorating patients. And I'm so sorry, but that's really the time I have. So I was going to run through some scenarios, but I've got to get to a list now. Look, the one thing I wanted to talk about was quickly the fact that, so I've got to talk here on crisis resource management. And again, CRM or crisis resource management is one of the most important things I know. That QR code leads to a lecture I've done on it. And really what I'm talking about is all of these non-technical skills that as a junior person, you don't need the privilege of, anesthetic rotation to learn. You can start practicing it even now. These are all the principles. I've just put them as actionable tasks here. Again, take a screenshot and look at the lecture for more detail. But the thing that will really make a difference to these patients once the knowledge and technical elements are sorted, which is the rest of your team, is am I mobilizing resources and cognitive aids? Have I got help? Who's leading this situation? Make sure there's a leader. Getting second opinions, anticipating and planning the future problems. Like for example, the anaphylaxis, maybe I need to send them to ICU. Maybe they need an infusion. Maybe I need to remove the trigger. Maybe this renal failure patient who's arrested is definitely going to have a high potassium and needs some kind of vas cath put in. You're thinking ahead. You're planning for the inevitable badness. It's really crucial. And when I think of, like, let's say these two scenarios we were going to run through, sepsis and post-op bleed, most of the actionable tasks are the same. Get help, active fellowship and leadership staff, get some cognitive aids, surviving sepsis guidelines or the ALS guidelines, call your mate on the phone, call ARV to transfer. But then if you think about the unique problem, the multiple priorities are very packageable things like I need to get fluids, BP and lines. That's the that's the cardiovascular stability stuff. I need to organize antibiotics and the right broad spectrum stuff. So you might coordinate with one of the nurses to get you stuff. But you can organize your teams to target these multiple priorities. Same with a post-op bleed. A lot of the common actions are the same. Get the people you need, emergency buzzer, etc. Leadership fellowship. Look at your protocols and guidelines. Use them because they're so useful to offloading your memory. But then think of what the multiple priorities are. You're losing fluid and you need to stop the bleed. So how do I treat this cardiovascular problem? Fluid, IV access, blood, cardiovascular support, and then the solution of stopping that post-op bleed, organizing theatre, transport, getting the surgeon in. Far more detail in my lectures. I'm so sorry I've got to cut that short. But yes, that's kind of the range of things that I found most useful that I didn't know about when I was going through my junior years. So this framework is, are they sick? Doctor's ABCDE, reversible causes, and then crisis resource management, even done at this level. Yes, and I'll definitely give you access to these slides. So I'm so sorry, that's all I've got time for, but any questions before I run off?
Just had a quick question. Would you take blood cultures alongside the VBG if you're thinking about sepsis?
Yeah, and stick to all your normal hygiene protocols, but absolutely. As soon as I take blood, I take more blood than I need because often the VBG comes back quickly, effective for answers, but then taking the proper FBE, coags, UEC, CMP, grip and hold and cross match, especially if you're thinking it's a blood loss thing, and then anything further, as long as you did it with the right aseptic technique. Absolutely. I know that often you'll need to do a proper scrub for some blood cultures, taking or other specific things. I haven't taken cultures in a long time, so I don't know what exactly the protocols are now, but it may have to be done in a more clean fashion, so you may wait to do that on another site where you're not in such a hurry. Good question. So really welcome. Thanks for joining me here. Thanks for having me, Sean and team. Welcome to the start of an amazing journey. I am so happy that I did medical as a career. It's just been extremely rewarding. I'm just so happy that you guys are at the start of this journey. It's fantastic. Don't rely on memory. I'll send you these slides. You've got apps with so much information, more than any individual can teach you, and the framework is reasonably simple. Following that framework allows you to not miss anything. Thanks very much, everyone.
Lahira, thank you so much for that. A great first lecture for these guys, and all of these are uploaded to WeLearn, so you can have access to them.
Beautiful.
We better let you go to your list.
Yeah, sounds good. Thanks, Sean. Thanks, team.